What's up, everybody? Welcome back to episode 2 of Pain Points with Dr. Miles Nicholas and yours truly, Dr. Michael Mash. Today, we're going to talk about how to have conversations with clients about their MRIs, specifically from the view of the fitness professional, strength coach, personal trainer. So, my question for you, Dr. Miles, is this. Let's say you are working as a strength coach in a gym. Let's assume you're a strength coach, so you're not a physical therapist. Step out of your PT shoes for a second.
Yeah.
You're a strength coach, and you get a new client. And on day one, you want to have that client do some sort of a deadlift. Let's say you're going to have them do a conventional deadlift on day one. And when you go to let this client know, and you say that D word, right, deadlift, I'm going to have you do some deadlifts today. Let's say that a look of terror comes across the client's face and they say, I can't do deadlifts. I have a herniated disc in my low back. What do you, as the strength coach, say to that question?
Yeah. No, that's. I mean, it's a very common, but also a very tough scenario. So I think the starting point is gathering information.
Of course.
So as a strength coach, I would ask first and foremost, where have you heard this from? In the sense of who told you had a herniated disc? Did someone say specifically like you're not supposed to deadlift? Do you currently have pain? Just getting as much information from them as possible so that before, you go in and start trying to intervene and make decisions with them, you feel like you have an even ground. Because for all you know, there might be a client who on that day one, maybe you're like, okay, maybe I don't want to deadlift because maybe they say, I do have some pain and I'm nervous about it, and so I'd rather not do it today, right?
Yep.
So I think going in and just getting all the information is the most important starting point.
Gotcha.
And I think even furthermore, worst case scenario, you don't deadlift that day. Worst case scenario, you just focus that first day on building rapport, making them feel comfortable, and you address it a little bit down the line.
Yeah. Missing one day of deadlifts is not going to affect. I mean, I used to be like this. I when I was younger, in my late teens, like if I had a back tweak and like I could not fathom skipping a day of deadlifts because my gains, right, they're all going to go away.
Yeah.
Like you can't skip
Your glutes
one.
would go to sleep.
They would go to sleep in one day, right? So now like we realize we're helping people build resiliency for life.
Right.
And if it's one day of not doing deadlifts because you need to build some rapport and find out some more information, it's one day.
Right.
You can do other things.
Right.
So let's run, I think you answered that exactly how I would have answered. So let's run through a couple different scenarios. So let's say that they tell you, the same client says, oh, I don't have any pain anymore whatsoever. All I know is that I used to have back pain. And when I got an MRI 2 years ago, it showed a herniation in my lumbar spine.
Right.
How do we progress from here? So completely asymptomatic. Yep. They had prior episode of back pain. They had imaging, so they know something that there may be a herniated disc there. How would we attack that from a strength coach perspective?
Yeah. So I think anybody can be educated on what research tells us. And I think there are especially like very common things that it's worthwhile. I don't think everyone needs to know the base rate of every single imaging finding in every single person, but I think disc changes are one that it's good for anyone working with fitness athletes or rehab clients to know. And because when we look at that, we know a couple things. We know that disc changes with advancing age it's a normal finding. So we know that someone it's basically the graying of hair, but on the inside, right? So that's one thing that's important to know. What I will say is in this instance, they did have back pain at the same time. Maybe it correlated to it, maybe it didn't. We don't know. But furthermore, we know that discs heal. It's around 70% of discs are going to demonstrate natural healing resorption over time, over like 9 months typically. And furthermore, that it doesn't always, like having disc changes on imaging doesn't always correlate with pain. Exactly. So I think giving the person the education that it's been 2 years, you are asymptomatic, I recognize that happened then, but that doesn't mean that if you feel open to it, we can't find a starting point with this movement pattern because of all the benefits that it gives us, and then progress from there.
Gotcha. Yep, I would agree, and I can keep playing off of what you said there. A herniated disc on MRI alone is not a contraindication to deadlifts.
Yeah.
Alone. You have to figure out where the person is right now, if they have symptoms right now, and start there. So we don't treat based on what the MRI shows.
Right.
And as a strength coach or personal trainer, you should not prescribe exercise based on what the imaging shows either. We don't prescribe exercises based on the imaging, and personal trainers and strength coaches shouldn't either.
Right.
It's all about what can that person do in front of you right there on that day one when they're with you.
Yep.
So in this case, where a person is asymptomatic, you've already touched on the fact that, okay, the MRI was 2 years ago. They don't need a follow-up MRI, but even if they did, let's say they did get a follow-up MRI, it could look totally different from 2 years ago. Right. But my point is that's kind of irrelevant because that's not the route we would go anyways. It's part of the education we would give them. Right. It would be saying, hey, look, discs can heal. That MRI was 2 years ago. It may not even be there anymore, but that might not be the route I would go down. I would mention it. My main route would be this. It's all based on how you're doing right now. So the herniated disc alone is not a contraindication. Right. So I think that would cover that scenario. And this is the education I would be providing as a strength coach. Do you have anything else to add to that specific scenario of asymptomatic prior MRI? Anything else to add to that?
No, not really. I mean, I think it comes down to, for everybody, talk to them, make a game plan with them, little by little. If they're not comfortable with it today, you work on it and you help them move towards their goals.
Gotcha. So let's add a twist to this scenario. Let's say that same scenario, MRI 2 years ago, no longer has pain today, but the client then tells you, my doctor said I'm not allowed to do deadlifts. What do you, as the strength coach or personal trainer, reply to that?
Yeah, I think that's definitely a harder situation.
Yeah, adds another variable into the equation.
And I think it's one of those things where still finding out some more information is important. Did the doctor say that to them 2 years ago when they last saw them, when things were starting to improve and they decided to kind of end that course of treatment together? If that's the case, then I think you educate them on how the deadlift in general is an exercise that exists on a spectrum in terms of stress, and it's a situation where you can start low and go slow. If this is a situation where the doctor told them that 2 years ago, but they also had a follow-up 6 months ago and the doctor reinforced that, I think that's invariably a tougher situation.
Yeah, so let's talk about that because many times the doctor does not specifically put a time frame on it. Right. They just say no deadlifts. For example, I had a slap repair on my right shoulder in 2011, and I was told no bench, no dips, no overhead press. Right. That was the sentence. Right. So, and then he walked out of the room. So I'm left with questions like me 10 years ago, did he mean forever? Right, exactly. Is this a thing where I'm never supposed to do that? Right. And even then, my very early young pre-PT brain was starting to churn something's not right here. There has to be a time frame. So in your opinion, this is kind of turning into an interview of me interviewing you, but is there ever a situation when deadlifts are contraindicated for life? Totally?
I mean, I would say no.
Me too.
The reason I would say no is because it's an unavoidable movement in the world that we live in. Yeah. Anytime we pick something off the ground, it's some version of a deadlift.
Hip hinge
right?
deadlift, something.
Exactly. So it's the way I look at it is, if someone needs to start from a standing position with a 5 or a 10 or a 15-pound dumbbell and work on a top-down hip hinge, I'm fine with that. I will meet someone wherever they're at because I'm always thinking about the long term. Yeah. Right? Same. I'm thinking, how can I little by little get this person to engaging more with their life or meeting their goals? Yep. So I will start as low and slow as I need to, because throughout that process, we're talking, I'm educating them, I'm dispelling myths, I'm decreasing their fears. Yeah. And is it a situation where I need this person to pull 2, 3, 4 plates off the floor? No, of course not. Not necessarily. But I think at the bare minimum, getting this person to understand that there's absolutely nothing wrong with any given movement pattern. There are certain movement patterns that can become sensitized, but in general, dispelling myths, getting this person to utilize this hip hinge deadlift movement pattern again in their life is absolutely going to play a role into them engaging with life in a meaningful way.
Yeah. So I want to clarify something for the personal trainers and strength coaches listening to this. Let's say in our scenario that when we ask for more questions and we say, well, did your doctor put a time frame on this? And let's say the client says, yeah, my doctor said no deadlifts forever. Like the doctor, the physician specified. We as a brand, Barbell Rehab, and me personally as a physical therapist, I would never recommend blatantly going against physician orders. It's just not something you should do. So we are not recommending, if you have a client who specifically had the physician say no deadlifts forever, what I would do as a strength coach is I would just reframe the exercise. I would note this. I would say, okay, I understand that your physician said that you're not allowed to do deadlifts forever. What I might say in that situation is this: we're going to try a different variation instead. Let's try this exercise called a kettlebell hip hinge, right? So is it a deadlift? It's semantics at this point. It's a hip hinge. Right. So in my opinion, we know that we just said that there's not really anything that we can think of that it would be a complete contraindication to a hip hinge for life. But if there is an avoidance or if there is an order that says no deadlifts forever, let's just reframe it and say, okay, we're going to try a kettlebell hip hinge instead. Keep the person in the pattern, find an entry point, but respect that the fact that physician said no deadlifts, just reframe the exercise.
Yeah, and the only thing I would add on further is that, after that person is feeling good, feeling comfortable with this hip hinge pattern, try and communicate with the doctor and say, hey, this person that you saw in the past is doing really well now. They're tolerating this, this, and this. I want to start doing some lifting from the floor. Is it okay with you if I begin this process and build it up over time?
Yep, get some information. That's it.
And then once again, you're making more relationships, more communications with other healthcare providers.
So the last thing I want to talk about before we wrap up is situations where the hip hinge or the deadlift may be contraindicated altogether. So let's say as a strength coach, you get a new client and they mention that they've been dealing with some leg and back pain. And so you keep that in the back of your mind. And then you go to do your movement assessment, which in my opinion, a movement assessment is just, let's take them through different patterns and see how they move, right? We don't need to overcomplicate it. And let's say you coach them into a hip hinge and they report shooting leg pain the whole way down the back of the leg, glute, hamstring, calf, the whole way into the foot on just the first rep of a body weight tops down hip hinge. What do you do as a strength coach? Is this something where we're going to say, just ignore it, we'll just RDL through it and hope it goes away? What would you do?
So no. That's a situation where I think if someone is getting that back of the leg pain where it's shooting down, like you said, I think that's a situation where I'm not just going to have them push. Because when we talk about different pain presentations, that's one where we have decent evidence that says we should probably listen to what the body is telling us. So if the body really doesn't like that hip hinge pattern, it's developing routinely that shooting leg pain, I'm probably going to modify around it. Could even be a situation where if this is new and hasn't been assessed by anybody, and we find that it's not just it happened on one rep and it's there and gone. But if it's sticking around, I keep an eye on that for a short amount of time. But if that's not improving, I would even refer that.
Or I would instantly be referring out if the client also starts talking about, this is affecting my everyday life, right? I'm having trouble walking, I'm having trouble going up and down stairs, which most of the time going up and down stairs is not really affected that much by this issue. But walking, prolonged postures, prolonged sitting, if somebody's is having trouble functioning in their everyday life, even outside of the gym, I might be even referring out instantly. So.
And a different question there would be, so what if someone comes to you, they were going to PT because of this radicular pain, they've gotten through PT, they still have some of this tension, some of this radicular symptom, but it's not so much that 6 out of 10 shooting pain it was, now it's there. And now they're coming to you as a strength coach. How would you handle that differently?
Gotcha. Yeah. So now they've been assessed, they've been evaluated, they've been through a plan of care, and they've been discharged. So as we talked about in Pain Points video 1, this is a time where as the strength coach, ideally, I'd like to collaborate. I'd like to give that physiotherapist a call. Hey, can you, any information I have so-and-so with me, any information you can give me, guidance, but let's assume that's not the scenario, because ideally in a perfect world it would be. If that's the scenario, I'd be gathering this information from the client. I'd be saying something like this. Okay, I understand you went through some physical therapy, and the good news is, now that you told me you're doing a little bit better, the natural course of this thing is that it's probably going to continue to get better.
Little by little,
Yep, over time. So I would still be going by our 4-step framework. I would be making sure that I select exercises that don't flare this up.
Yep.
And if I find a pattern that does flare it up, number one, can I first modify it so the pattern no longer flares it up? Right. And two, if I can't, then I'm just not going to do that exercise right now.
Yep.
And I'm going to find something else to do. And if the hip hinge pattern is indeed the pattern that is causing the radicular pain, I might just not hip hinge for 6 to 8 weeks and maybe revisit it later.
Yeah, and I think that's the question, is like, when's the right time to revisit it? And I think the answer is when the person is no longer rating that leg tightness, that symptom, as pain, and it's like, oh no, I feel it, but it's okay. I think that's when you start to poke the bear again a little bit and start getting them into that pattern. Again, going back to like keeping an eye how that responds over 24 hours, how their tolerance to it is, not just during, but following. And then I think that's the point where you start to progress that pattern again. Exactly. And it's a situation where it's not necessarily going to be quick. It might take 2 months, 3 months. It might take quite a while, but there is always going to be that inflection point where we have to start addressing that movement again.
Gotcha. And guess what? If it does take 4 to 6 weeks, 6 to 8 weeks, that's okay.
Totally.
It's okay, right? We're training people for life.
Yeah.
And if it takes 6 to 8 weeks for a highly irritable pattern to desensitize, it takes 6 to 8 weeks. So, okay. So hopefully that what we just said gave you some guidance, whether you're a personal trainer or strength coach listening to this, or even if you're a healthcare rehab professional listening to this. Hopefully that gives you some guidance on how to better manage that question of the MRI, right? I have a herniated disc, I can't deadlift. So that'll wrap it up for this video, and we'll see you on Pain Points video number 3.
Cool.